Many organizations have been doing important innovative work in their local healthcare environments to try to solve problems related to bias and discrimination in medicine. Naming and addressing forms of medical racism, including inequities in care delivery, outcomes, and experiences of care, can catalyze important conversations and efforts toward care transformation. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Heather Shue, a pediatric hospitalist at Boston Medical Center and an assistant professor of pediatrics at the Boston University Chobanian and Avedisian School of Medicine. Dr. Shue has co-authored a perspective article about an institutional health equity conference series as part of the journal series of brief case studies of anti-discrimination initiatives. Dr. Shue, in your perspective article, you described the Health Equity Rounds conference series developed at BMC in 2016. So, what problem was the program designed to address, and how did you choose this particular approach?
So the Health Equity Rounds program was designed to address the impact of bias, structural racism, and other forms of systemic oppression on health and healthcare, and really allow for space for us to have conversations that may be difficult about what we're going to do about it. At the time, those conversations really weren't being had in healthcare settings.
Can you describe the logistics of the program? How often are the conferences held, and how are specific topics chosen?
In our program, we hold the conferences in the Grand Rounds space. We deliberately wanted a space that was generally protected for most faculty and staff to be able to take time to attend, and we wanted it to be interdisciplinary in nature. We have conferences quarterly, approximately. Sometimes we have more than 4 conferences per year, and each conference lasts about 1 hour. At this point, our program is quite mature, and so we generally have folks reaching out to us with cases that have bothered them in some way that they want us to dig into more. Or we have members of our presentation team who've had an experience as a practitioner that they want to explore using this health equity lens.
So, you say in your article that the topics are researched and presented by residents with faculty mentorship. Why is it important for trainees to take the lead in these conversations?
Our Health Equity Rounds program is coordinated by pediatric residents, but that's actually not the case for Health Equity Rounds programs throughout the country. Other programs have much more multidisciplinary preparation groups. We feel that the benefit of having residents take the lead in these conversations is that they get to be the teacher rather than the learner, and they often have a lot to add in this space in terms of their expertise that they bring to the table. We also feel that it gives them a really valuable opportunity to be up on the Grand Round stage, to learn how to talk with clarity and purpose about difficult topics like medical racism, and to learn how to take the lead in solution finding at the institutional level.
And how has normalizing conversations about medical racism influenced the day-to-day discussions in your department? And how has it affected patient care, do you think?
So I think our Health Equity Rounds program has given members of our department a vocabulary for having conversations about medical racism and allowed us a space to begin those conversations. This has served as a nidus for additional conversations that may happen outside of the Grand Round space, where members of our department will often mention having a Health Equity Rounds moment and use that as the start of a new conversation about a problem that they have encountered in clinical care. For us, Health Equity Rounds has helped serve as a conversation starter for institutional change and has allowed us to begin the difficult work of change making by naming a problem, brainstorming solutions, and then coming up with an action plan to try to change our way of operating in order to impact clinical care. We have a couple of examples that I could bring up to talk about that in particular if you're interested.
Yes, I mean, in fact, you say in your article that there have been concrete policy changes at your institution. So, what are a couple of examples?
So, one major example that is still very active right now is we had a two-part Health Equity Round series back in 2018 and 2019 on caring for families affected by parental substance use. This was the start of a series of really important conversations that our institution had we convened a multidisciplinary committee to review current laws and institutional practice related to reporting of prenatal substance exposure to child protective services. And over the course of several years, a lot of listening sessions, a lot of committee meetings, we ultimately created a new clinical guideline that rolled out in 2021 that advised clinicians in our hospital to report suspected abuse or neglect only when there were tangible concerns about a parent's ability to safely care for their child, rather than automatically reporting for all cases of prenatal substance exposure. So this would then eliminate reports that were filed for families where the birthing parent was taking prescribed opioid medication for sickle cell disease or medications for their opioid use disorder. We then had members of our Health Equity Rounds resident team conduct a statewide analysis demonstrating that this guideline change reduced our Child Protective Services reporting by about half. And after we published that study, the largest hospital system in Massachusetts adopted similar guidelines. Our resident team members have been very active in legislative advocacy around this area, have been able to meet with leadership in the Department of Children and Families, meet with leadership in the Department of Public Health in Massachusetts, and testify before the Massachusetts legislature in support of a now pending state bill that would eliminate automatic child protective services reporting in the absence of safety concerns for all substance exposed newborns throughout the state. And this bill is still pending right now, so we're still actively doing the work in this area. Another successful initiative that was sparked by Health Equity Rounds conversations was a change in the way that we incorporate safety flags into our electronic health records if there is a patient or a family member who has had a history of having difficult interactions with staff. So we now have a committee that can review those flags, and we have processes for removing them if we feel that they have been entered into the electronic health records with bias.
Finally, how did this model spread beyond BMC, and what steps have you taken to support other institutions that have wanted to implement this sort of health equity rounds?
The first thing that we did was we started presenting workshops at national conferences like the American Academy of Pediatrics, National Conference and Exhibition, or the Association of Pediatric Program Directors annual meeting to get out the word about what we were doing. We also published a how-to guide in the journal MedEd portal that others have seen and then used the lessons learned from. We also do a lot of one-on-one institutional mentoring. So an institution will hear about the program, reach out to us, and we then meet with them, usually via Zoom, to talk about the program. We often will present an initial health equity rounds conference at their institution and then help support them in taking the reins from there. We've seen about 65 different institutions do this successfully, and there are actually many more programs who've had no contact with us but have just picked up the program on their own through word of mouth or through one of the publications that we have made.
Thank you, Dr. Shu.